Hello and good evening, ladies and gentlemen. And for those of you that don't know me, and most of you probably will by now, my name is Carrie, and welcome to our third winter webinar on behalf of the ERS. And it's a pleasure to bring you this in conjunction with our sponsors, Olympus. I'm really looking forward to this evening's webinar. We've gone endonasal into some core rhinology this evening, and I'm looking forward to hearing our moderator and speakers. So I'll be passing over to my co-moderator Cecilia to introduce her speakers. For those of you that are new to the ERS Webinar Series, just remember that we don't use the chat function. But please type in your questions into the Q&A function, and we'll answer your questions at the end of the session. So, Cecilia, thank you very much, and over to you.
Thank you, you're all very welcome to this webinar. My name is Cecilia Ahlstrom Emanuelsson, and I'm an ENT doctor in Sweden. And today our subject is about GPA, vasculitis, and the practice of that. And the first speaker is Professor Segelmark, who is working at Lund University Hospital here in Sweden. So I pass over to him to give an overview over this disease or diseases. Please, Martin.
Thank you very much, Cecilia, and thank you very much, Sean, for inviting me to give this presentation. As Cecilia said, I'm a nephrologist working in Lund, Sweden, and I have had an interest in autoimmune disease affecting the kidneys all my professional life. And today I will talk then about granulomatosis with polyangiitis. And this will be a relatively standard presentation as it comes. I will talk about definition, classification, symptoms and signs, diagnosis and epidemiology, and pathogenesis, and then a little bit about treatment and prognosis. First of all, I would like to say a little bit about the name. Granulomatosis with polyangiitis were earlier called Wegener's granulomatosis. So why have we changed the name? Well, in ICD-10 that we still use in Sweden, at least, it's M313 is still Wegener's granulomatosis, while at the Chapel Hill Consensus Conference on the nomenclature of systemic vasculitis, it is now called granulomatosis with polyangiitis. This is a terrible name. It's a tongue twister that hardly any patient can ever say, and even less tell their relatives or friends what type of disease they have. So why not saying keeping with Wegener's granulomatosis? Well, there is a reason for this. Actually, Friedrich Wegener was not the first person to describe the disease, but that is maybe not a problem. That's not a lot of diseases that have been described by other persons. But more importantly, Wegener was a Nazi. He joined the National Socialist Party long before it was in any case mandatory, and he had friends and relatives working very hard for the Nazi regime. He was himself a military doctor, and he volunteered to work in Poland. He worked as a pathologist close to the ghetto in Lodz, and there are a lot of autopsies signed by him from the ghetto area, and he maybe also participated in research on human subjects. After the war, he was arrested by the British Army and was kept in custody as a suspected war criminal, but he was never convicted of any crime. But most importantly, he never disclosed his wartime activities or expressed any type of regret for what he had participated in, even though he was active in the scientific life up to his death in 1990. So with that in mind, and that's a good report in the Lancet about this, written in 2006, that really made a big change here to get away from Wegener's granulomatosis. And I think that's very good if you know this. So it's sort of a political statement just to keep with an old eponym here. What is the definition then of GPA? Well, there are different types of primary systemic vasculitis, and they are divided depending on the size of the blood vessel they affect into large vessels, medium-sized vessel, and small vessel vasculitis. And the small vessel diseases are divided into two main groups: those in which the pathologist can find immune complexes, and those where there are no immune complexes found. And this group, also called the pauci-immune small vessel vasculitis, or have another name, that's ANCA-associated disease, and that because all of them are linked to the anti-neutrophil cytoplasm antibodies, which I will talk a little bit more later. There are three different diseases in this category, now called then MPA for macroscopic polyangiitis, GPA for granulomatosis with polyangiitis, and EGPA, eosinophilic granulomatosis with polyangiitis, that was formerly called Church-Strauss disease. All these diseases are chronic inflammatory diseases that are biphasic. They have a prodromal period and also periods of remission, where there is chronic inflammation, and this inflammation is most often in the respiratory tract, and then can be of interest for ENT surgeons. EGPA, there is asthma and very often nasal polyps. In GPA, it is a lot of different inflammation in the respiratory tract: rhinitis, otitis, sinusitis, pulmonary nodules, laryngitis, and other problems that we will hear more about later today. And in MPA, microscopic polyangiitis, it is very common with pulmonary inflammation, pulmonary fibrosis, that can precede the vasculitis with many years in many cases. And then what is then typical for these diseases is that these long periods of inflammatory disease that could be sometimes below the clinical radar. There are subacute episodes with systemic inflammation that we call flares and exacerbation. And then it is very common with rapidly progressive glomerulonephritis, and that's why I have an interest in this, because this is the most common reason for rapidly progressive glomerulonephritis that can destroy the kidneys in a couple of months. And they can also affect the small capillaries in the lungs, leading to pulmonary hemorrhage. So how do we make a diagnosis today of GPA? Well, the patients need to have some sort of symptoms. They could either be typical or compatible with GPA. Then depending what more we have, if we have histology, it is enough that you have a disease that in some way can resemble GPA to make the diagnosis. But on the other hand, if you only have serology or radiology, you need a very typical constellation of symptoms to be able to make the disease. As it's usually quite difficult to get positive histology if the kidneys are not involved, we very much rely on serology for early diagnosis. And for that reason, I will dwell a little bit on the serological diagnosis. The main diagnostic serological test that we rely on are the anti-neutrophil cytoplasm antibodies. These are antibodies directed against granule components of the neutrophils. They are implicated in the pathogenesis, and they can, at least to some extent, be used as marker of disease activity. But we must keep in mind that ANCA is by no way completely specific for GPA or for ANCA-associated vasculitis. They can be found in many forms of other inflammatory diseases, in inflammatory bowel disease, liver disease, infections, in malignancies, and sometimes also in adverse drug reactions. ANCA can be, there are many ways to detect ANCAs. Traditionally, it was done by indirect immunofluorescence using neutrophils. They were fixed with ethanol on a glass slide, and then conjugated IgG antibodies were put on the slides. And then different patterns could be distinguished, similar to antinuclear antibodies. And we have the P-ANCA pattern. I'm sorry here, I have misspelled. It should be a C-ANCA on the top. So there are different patterns, the P and the C-ANCA patterns. And this was the traditional way to diagnose these antibodies. And this is also what the name come from. But it didn't take many years before immunochemistry or chemistry had detected that what the antibodies are, and the major antigen for the P-ANCA, it was myeloperoxidase, and for C-ANCA it is proteinase 3. And when these antigens were detected around 1990, ELISAs were quickly developed. And the ELISAs, they found that there were also more antigens, even though they were not so of any major importance for vasculitis. They could be found in other diseases. And in that way, ELISAs with PR3 and MPO made the diagnosis more specific. But there were problems with the sensitivity. So that not all cases were detected with ELISAs. And for that reason, for many years, the general meaning was that immunofluorescence should be used for screening, and then when positive, specificity should be detected with ELISA. However, that have changed, and now more recently there are third generation tests out. They have been out for quite a while, but they have now been compared. And this slide shows different tests, showing the immunofluorescence test here in blue, which has definitely the worst ROC curve, while more modern and tests, including the platforms used now by many clinical immunology laboratories, have really excellent ROC curves with very good both specificity and sensitivity. So with this in mind, there is no reason to stick to the old immunofluorescence tests, and you can start directly with one of those Luminex or CLIA or FIA or whatever the tests are used. But you should be aware what is available at your local laboratory in order to be able to interpret if you have a test with very good sensitivity or specificity, or if your laboratory sticks to an old-fashioned ELISA or immunofluorescence test. That makes a big difference in the ability to detect these antibodies. So what about the incidence of these diseases? Well, we made epidemiological tests here in the area of southern Sweden, and we found in 2009 that the incidence was around a little bit of more than 20 of ANCA-associated vasculitis, half of them approximately being GPA. And actually, this is what they have found in many other parts of the world. And more recently, they have found an even higher incidence in the United States of 33 per million. Now when testing is also more common in older age group. So somewhere between 20 and 30 is what have been found in most modern studies, which and then about half of them GPA. It gives an a incidence of around 15 per million. That would be about 150 in Sweden per year. So it's still a relatively rare disease, but not at all as rare as it was considered some 20, 30 years ago, when it was thought to have an incidence of about 1 per million. So what do we know about the pathogenesis of this disease? Well, as I said before, there are two steps in the disease process. There is first the chronic phase with the granuloma formation. Granulomas are by definition contain multinucleated giant cells, and they are formed on the influence of T cells. It's a mixture of T cells and macrophages that will lead to the formation of these giant cells. Actually, what they are trying to engulf in GPA is not known, but there are theories that there are maybe dead neutrophils that have concentrated in some area. And this then leads to the formation of these ectopic lymphoid tissues that surrounds the multinucleated giant cells, with a lot of T cells, B cells, can actually form germinal centers. There are a lot of studies showing that T cells behave in a somewhat aberrant or awkward way. I will not go into those details now. Then something happens and we get this widespread inflammation in the body, the vasculitic phase of the disease. Then we believe that neutrophils start to expressing the ANCA antigens on the surface, and then ANCA will bind to the neutrophils. That will lead to release of proteases and complement components, and there is an activation of the alternate pathway locally, which in turn leads to generation of complement factor C5a, which recruits more neutrophils to the sites, and this creates a vicious circle. So what happens to the neutrophils? Well, they undergo a special form of cell death called neutrophil extracellular traps, where the neutrophils turn themselves into some sort of a web of DNA decorated with antimicrobial proteins. This is really meant to ensnare and kill microorganisms, but when this happens inside the vessel wall, it leads to vasculitis, and in the kidneys, crescent formation. You can compare this a little bit with these Roman gladiators that throws out the nets to kill their opponents. These nets, neutrophil extracellular traps, they can cause vascular damage through proteolytic enzymes, through reactive oxygen species. And they also, on the surface of these dying neutrophils, you get complement activation, alternate pathway. It also leads to coagulation and thrombosis. Actually, all types of thrombs formed in pulmonary embolisms and venous thrombosis contains a lot of these nets. And the histones that are released are toxic to the kidneys and to other blood vessels in the body. We and others have shown that neutrophils from patients with GPA are less prone for apoptosis and more prone to undergo netosis. And it's easier to induce netosis, have been shown in other experiments. And there are also molecular explanations for this, which I don't have time to go into in detail. So why this can then show that the antibodies are important. So why do we make the antibodies? Well, a common theory in the field is that this is due to molecular mimicry, that pathogens sort of mimic something in the body. But this does not necessarily have to be the case, because we are all expressed with something called natural antibodies from the beginning that or resembles autoantibodies, but that are found in low concentrations prior to immunization. It can be found also in mice that are brought up in completely germ-free environments. It is in mice, it's mainly IgM, but in humans, it's also IgG and IgA, and they are believed to be important to clear debris. It has been shown that in healthy persons, there are some of the B cells that react with the ANCA antigens. It was found in this study here that 0.33% of all circulating B cells were specific for PR3. It is more in patients with ANCA-associated vasculitis. They have a larger percentage of these cells. We showed that we could purify these natural antibodies from the sera of patients, and they were very specific, as shown by inhibition ELISA experiments. And very interesting is how drugs can induce ANCA. The most common drug to induce ANCA is PTU, which is used to treat thyroid disease. But maybe of more importance for ENT surgeons is the drug called levomisol, which is a veterinary drug, but it's impossible even for a drug addict to make a distinction between levomisol and cocaine. And for that reasons, as you know, that people selling cocaine are not someone you should trust. And it's much cheaper for them to get a hold of levomisol because anyone can buy it. They put it in the cocaine, and levomisol, similarly to PTU, will induce nets in neutrophils. And in PTU, these nets cannot be degraded, as shown here, by DNase. So they get these nets that are tangled and not easily degradable. And in animal experience, at least, if you inject PTU nets into rats, they will start producing ANCA, and they will start to get vasculitic symptoms. So to sum up this, what we believe about the pathogenesis, we think that we have this circle that I described earlier with neutrophils that die and start activation of complement, C5a generation, and more neutrophils. And neutrophils then go into netosis, and they produce nets, and then there are normally natural antibodies to take care of these nets. But if you overwhelm the system and have too many nets, you will get nets presented in germinal centers that will make, and the body will start making high affinity IgG antibodies to get rid of these nets, but this can backfire then and start activating the neutrophil and starting this circle over again. Well, this is at least what we think happens. So what can we do about it? Well, before the introduction of cyclophosphamide, this was a very serious disease with a 2-year survival of less than 20%. With cyclophosphamide, this changed to the opposite. So you had a 2-year survival of 80% instead of 20%, 2-year mortality of 80%. And actually, as you see here, the first publication of this was done by a man named Anthony Fauci, who is now became very famous as he is the leading corona fighter in the US and also one of the major opponents of President Donald Trump. But this was when he was young. He made this in 1979. He made this introduced cyclophosphamide in the treatment of GPA. But cyclophosphamide have a lot of disadvantages, causing infertility, infections, and cancers. So for that reason, there has been a series of studies made to reduce the exposure of cyclophosphamide through the years, which have led to the current recommendations that in less severe diseases, those affecting only the nose, you can start with methotrexate or MMF instead of giving cyclophosphamide. And in more severe cases, it is possible to use rituximab instead of cyclophosphamide, even though cyclophosphamide is still considered as a major treatment option. In the most severe cases, the add-on of plasma exchange has now recently been challenged and is not as popular as it used to be. But cyclophosphamide and rituximab are still the main treatment in most of the disease, in most cases. In recent years, there has instead been a movement to use less of steroids, which has been very important, and a lot of studies have been made to try to reduce steroid. And I will here just mention one of them with that they call the CLEAR study that was published a few years ago, and it is with a new substance, a C5a receptor inhibitor. And as I said earlier, C5a is very important for recruiting neutrophils and would therefore be able to stop the vicious circle. And as you can see here, when steroids were given in low doses together with this C5a inhibitor, or when actually no steroids were given, there was a faster time to remission of the renal problems. And even more importantly, when you see the response of quality of life, the dotted black line here is the steroid group, and you see there is hardly any improvement during the first 3 months in the patient's feeling of quality of life, but it's rapid improvement with the Vacopan that have a faster effect of stopping the disease. There has now been a phase 3 trial with this substance. It's not published yet, but preliminary results have confirmed this, and this will probably be licensed for GPA and MPA within the coming year. And this is very exciting because in autoimmune diseases, steroids have for 50 years or 70 years, I think, 60 years at least, been the drug of choice that has, or the backbone of all treatments. So to be able to replace this with an oral low inhibitor with very few side effects is very thrilling, at least for a nephrologist. So what about the outcome of the patients? Well, as I said, these are data that we took of our cohort here in Skåne. That's now about 15 years old. We had a 1-year survival of 87% and a 5-year survival of 71%. But this was heavily dependent on, these are all ANCA vasculitis, and this was heavily dependent on the age of the patients. We had actually no casualties of those that were 55 years and younger. And it was also very heavily dependent on the disease phenotype and the renal involvement, and with a better prognosis for those with GPA, here on this slide, still called granulomatosis, and MPA, which have more renal involvement. And the results coming out more lately from the US have shown an even better outcome. And that has especially, we have been better now with lower steroids treating the elderly patients. So with this, I would just like to acknowledge my co-workers working on vasculitis here in Sweden and abroad. And just to say that GPA is a severe disease that can affect many parts of the body, but it can be treated, and there is hope for an even better treatment to come up soon. So with this, thank you very much, and I'm ready to take questions now or after my Dr. Briner's lecture here.
Okay, thank you very much, Paul and Martin, for this excellent overview of this disease. And now I think I'll hand it over to Hans-Rudi Briner from Zurich, who will talk a little bit more closer to what's happened for us as ENT doctors in these diseases. Please, Hans-Rudi.
Hello, here I am. So, dear Cecilia, dear Sean, dear Martin, it's a great honor for me to talk about the ENT manifestations of granulomatosis with polyangiitis for the next 18 minutes. First of all, I have to disclose some disclosures. This is mainly a consultant contract with the Karl Storz company and some relationship with the company which gives license to the smell diskettes test. We heard in the nice introduction by Professor Martin Segelmark that granulomatosis with polyangiitis was described already 89 years ago from now. First by Klinger and 5 years later by Wegener. And you also heard why the disease now is renamed in granulomatosis with polyangiitis. It's because of the role, which was unclear, of Wegener during the Second World War. It is a systemic disease. We heard that quite impressively in the last talk. So it is more specialized, a autoimmune multisystemic small vessel vasculitis. It is a rare disease, and I found in the literature a prevalence in Europe which is a bit higher than what we already heard by Professor Segelmark, up to 5 to 100,000. But there are regional differences in the prevalence of the disease. It affects predominantly Caucasians, and the male to female ratio is roughly 1:1. We find a wide age range. It may go from 8 to 99 years, with the mean age at diagnosis of 40 years. As we heard, it is a systemic disease, which is characterized by the necrotizing granulomatous lesions of the respiratory tract. Furthermore, we heard about the systemic vasculitis and the reason for that, and of course, the glomerulonephritis. Under clinicians, it's also known as ELK disease, E for ear, nose, and throat, L for lungs, and K for kidneys. As we know, upper respiratory tract involvement is there in almost all patients of GPA. Most commonly, the nose and the paranasal sinuses are affected, whereas affections of the ear and temporal bone is a little bit less common, with an involvement of about 40%. More rare are affections of the larynx. What is important for us to know is that ENT manifestations are often the first sign, the first manifestation of the disease. And it's also important to realize that the symptoms are often very unspecific. They have a wide range of severity. It may be from mild to extremely severe. And these facts make the diagnosis a real challenge. However, it is important to establish an early diagnosis in order to prevent an unfavorable disease process, because we have the experience, and this is also down in the literature, that a earlier treatment may cause some prevention of a fatal course of the disease. So let's have a look at the ENT manifestations. We start with the most infrequent manifestations, the laryngeal manifestations. They are there in a prevalence in the literature of about 6 to 20% of GPA patients. The leading symptoms are again very unspecific. The most common reported symptom is a reduced exercise tolerance. If you have a more severe manifestation of the laryngeal mucosa, then we may find the symptom of a stridor. The clinical finding is most common a affection of the mucosa in the subglottic space, so this may end in a subglottic stenosis. Well, let's move on to the second most common manifestations in the ENT area. These are the manifestations in the ear and temporal bone. In literature, these manifestations are found in up to 40% of GPA patients. These manifestations are characterized as unspecific inflammatory lesions of the middle ear and the temporal bone. The most common presentation seen by clinicians is a serous otitis media. However, also subacute and chronic forms of otitis media and mastoiditis are seen, and what's typical, they do not respond well to antibiotics. Furthermore, the disease may be bilateral. And this is what you have to remember. If you have an inflammatory affection of the ear of the mastoid, which is not responding to antibiotic treatment, which is even bilateral, then you have to think of and exclude a GPA. There may be also an involvement of the facial nerve. And in literature, it's written down that facial palsy may be found in up to 8 or 10% of the GPA patients. An involvement of the inner ear is also quite frequent. And typically, we find a combined hearing loss, which may again be bilateral. There may also be a specific vertigo, which makes the diagnosis even more complex. So to summarize, the ear and temporal bone manifestations is that you should remember, if you have a case of an unusual clinical picture, inflammation not responding to antibiotics, bilateral manifestation, think of and exclude GPA. So let's move on and look at the nose and paranasal sinuses. Well, it's a ERS seminar, so we are the Rhinologic European Society. Nose manifestations are the most common ones and can be found in almost all patients of GPA. The symptoms, however, are rather unspecific, such as nasal blockage, crusting, and maybe a little bit more specific, blood-stained rhinorrhea. Quite specific is the prevalence of, the finding of a septal perforation, which can be found in 1 out of 4 patients with GPA. Very common, we find a bacterial superinfection. And the most common strain that can be cultivated is Staph aureus. I mean, look at this terrible picture of this nose. Biopsy is not always conclusive. Quite often, we are confronted with a histology report of a unspecific inflammation. So, and we heard this very nicely in the previous talk, the diagnosis must be established by A, the clinical picture, B, the biopsy, and C, the ANCAs. Differential diagnosis. Cocaine-induced vasculitis is a thing you have to think of. And we heard the role of this material, which is also in the cocaine, this antihelminic drug, and probably this is the circle, this is the link of how cocaine may induce some granulomatosis disease. We also have to exclude the eosinophilic form of GPA, the Church-Strauss syndrome. We have, and this is however quite rare, to think of a sarcoidosis, another systemic disease. And there are other quite rare disease entities, such as, for example, the natural killer or T-cell lymphomas. Here we have an endoscopic picture of a patient with GPA, of a patient with the eosinophilic form of GPA, the Church-Strauss, and of a patient with sarcoidosis. And what is obvious, that the patient with GPA has the most active inflammation of the mucosa, with crusting, with scars, with bloody secretion. If you compare this to the picture of a eosinophilic form of GPA, this does more look like a standard form of chronic rhinosinusitis with polyps, much less inflammation of the mucosal surface. And if we look at the sarcoidosis patient, the granulomas are not at the surface of the mucosa. Complications of GPA are quite common, and you may find a dacryocystitis, as you can see here in this patient. There may be also orbital involvement. And typical to these complications, again, is that they do not really respond well to antibiotics. It is furthermore of great importance for you to know that surgical therapy in GPA usually leads to an uncontrolled scar formation. So if you have a case of a typical form of chronic rhinosinusitis, try to exclude GPA, because you should avoid surgery if ever possible in patients with GPA. These recommendations are also written down in the actual EPOS 2020 publication. Here you can see the management scheme on diffuse CRS. If we have a closer look at it, it is written down what we have been talking about, that in the presence of chronic rhinosinusitis, where you find bleeding and crusting, where you find a tissue loss, the septal perforation, where we have severe pain, involvement of other organs, you have to exclude a systemic disease, especially vasculitis, and this is the GPA, by ANCA, by biopsy, and by thinking of it. So let's come to the end with a typical case. We have a 40-year-old patient, 42 years old patient, presenting with a blocked nose, rhinorrhea, and crusts. And if we look at this patient, if we have the endoscopy here, we can find a septal perforation. We can also find some crusting, and you realize that the patient was also treated already by surgery. And have a look at the CT scan. We can see the septal perforation. We realize that the patient also had reduction surgery of the inferior turbinates and some form also of surgery of the paranasal sinus system. So this finding makes us suspicion to GPA. Treatment was established with topical and systemic steroids, but the patient came back with progredient symptoms, and he also reported pain in the right orbit. And now it was quite obvious there must be going on something different. It's not a atypical course. And look at the endoscopic picture now. You see that we have much more inflammation of the mucosa of the nose and paranasal sinus system. And you can see this also in the actual CT scan, which was performed at this time of the presentation of the disease. And if you have a closer look at the right orbit, you may detect also some involvement of the disease process, which is there in the medial and inferior part of the right orbit. And this is even more obvious if you perform a MR examination. You can impressively see the involvement of the inflammation also in the medial and also even central component of the right orbit. So the patient had highly elevated ANCAs, and the diagnosis now was clear. He had GPA with a septal perforation with a secondary diffuse form of chronic rhinosinusitis, and as complication with involvement of the right orbit. Interdisciplinary approach, systemic immunosuppressive treatment was established, as we heard before by Professor Segelmark. And fortunately, the patient is well now for more than 8 years with a long-term remission of the disease activity and of the symptoms. So let's come to the conclusion. We learned that upper respiratory tract is involved in almost all patients with GPA. ENT manifestations are often the first sign of the disease, and this makes us responsible for these patients, because we must think of the diagnosis. We should establish the diagnosis in order to give the patient an optimal prognosis of the disease. In case of an unusual clinical picture, think of and exclude GPA. It is an interdisciplinary approach what these patients need, and medical treatment is the treatment of choice. Avoid surgery if ever possible due to the tendency of a pronounced scar formation. So these, ladies and gentlemen, were the informations that I wanted to give you on the clinical ENT manifestations of GPA. Thank you very much.
Thank you, Hans-Rudi, for this very nice presentation. And as I will remind you, it's you can write down your questions on this Q&A. We have got one question that I will take now. And it's both of you. Is it appropriate to initiate anticoagulantia therapy? And if so, what of indication to use it? I think it's mostly for you, Martin.
Well, it's a very appropriate question, because there is no consensus on this. It is clear that patients with active GPA have a very much increased risk to develop venous thrombosis. And when treated, it goes back to almost to normal levels. It's a bit increased compared to others. But while the vasculitis is active, the risk of thrombosis is very high. If there are active lung hemorrhage, you should of course not use it. But I think that the trend is moving towards treatment for prophylactic treatment for thrombosis, but it's not yet there in any of the guidelines you can find. So I couldn't really say that I should recommend it, but it must be taken into consideration.
Okay, and I take one more before we take another case. In patients with severe nasal symptoms and typical nasal endoscopic appearance of GPA, but negative biopsies and negative serology, there is no confirming diagnosis. Do you ever use any oral steroids? What do you say, Hans-Rudi?
Well, it is a difficult question. Of course, when you have a high level of suspicion, you must discuss this with your team, and to try oral steroids is an option. However, when we do not have really established a diagnosis, we have to keep an open mind. In my clinical experiences, that sometimes we find the clinical expression of GPA, but the antibodies are still low and the biopsy is very unspecific. So you can maybe continue with the working diagnosis of a GPA, but you have to have an open mind and retry to establish a diagnosis. Maybe it's another systemic vasculitis. Maybe it's another autoimmune disease. Maybe it's a lymphoma. So don't just think, okay, now GPA and go in this direction. You may try oral steroids, but you need to re-establish the situation from time to time in these cases.
And what is the best location of biopsy? Now I'm thinking about the nose. I think so. I think it's Hans-Rudi.
Well, when you biopsy a mucosa which looks necrotic, then you will find necrosis. So what I learned from my pathologist or histologist, they say, go to the border of the lesion, make a large biopsy, not only a small bite with, for example, a Blakesley forceps, but excise a little bit more of the tissue. Then it's much easier to find some specific granulomas. And to be open, I hope in future, the pathologists may progress with the diagnosis, probably with some specific antibodies, immunofluorescence or whatever. But this is probably still a little bit in the future.
Okay. I think I give a share you some case here about Marcus, who is 31 years old. He is a healthy person, has no allergy, father's nasal polyps, and his first contact with ENT was in 2009. He has some problem with sneezing and snoring, but no treatment. Okay, and then in 2016, he comes again to the local ENT doctor. He has blocked nose, has anomisia, had several sinusitis, and the nose doesn't look so very good. It was edema, so it's red, it was secretion, and it was also small polyps. He gets some prednisolone for 3 weeks, some microlides, he gets the Mista, and he improved and didn't come to return visit. But in June 2017, his nose is very blocked again. He comes for regular mechanical cleaning of the nose. He's scrubbing, has septal perforation, synechiasia, and he's developed a rhinitis medicamentosa because he's blocked in the nose. He gets some new antibiotics, and he gets some more steroids, and he improved. Okay, and now in November, he comes for return visit. He still has a problem, but the doctor started to think. He took some blood samples, as you told before, Hans-Rudi, and taken nasal biopsy. It was just normal inflammation. Then it's gone another 6 months. He gets a new infection, and now it's Pseudomonas in the cultures. And another half a year, he come back again, and now it's also Pseudomonas. He's a really nose invalid. He can't do anything. He's just thinking about his nose. He's scrubbing the nose. We had a discussion about doing a full house fess. And the septal perforation is quite big. And he's referred to the hospital, university hospital. And in January 2019, the nose looked really, really terrible. Almost everything is gone. And now the PR3 anchor is positive. And we took a new biopsy. And the man looked like this. What do you think this is? What do you say, Martin? What would you think about this? Or do you recognize him?
No, I don't think I have met him, but maybe heard about him, so it's not fair that I guess.
What do you say, Hans-Rudi?
Well, it's an impressive disease process. And I mean, the symptoms and findings are very suggestive for a systemic vasculitis such as GPA. It may be also the differential diagnosis of levometazole-induced vasculitis or a thing like that. But I think the working diagnosis is a GPA. Yeah,
10 years use of cocaine. So it's not so very nice thing to see about. Or what do you say? No, I should stop sharing. And we take some more questions, I think. As you saw this nose, Hans-Rudi, what about when do you do reconstruction of such a nose? Or say the nose or deformity like this?
Well, this is another hot question. In patients which have a long-term abuse of cocaine, you should not perform surgery. I know that this is quite a hard statement, but the compliance in these patients is severely less than in a normal population. And when you have seen this nose, this would need major surgical reconstruction. And when you do this, and the patient goes back to his habit and uses cocaine again, he may destroy a huge and extensive surgical reconstruction. So you should be very, very conservative in considering a big surgical procedure as long as the patient is not really clean and safe and away from the cocaine abuse.
But if you have a normal, if you can call a person normal GPA patient who's not using cocaine and had a sudden nose and have a septal perforation, what do you say about operation there?
Well, when you have an autoimmune disease, first you should control the autoimmune process by systemic treatment. And when the disease process is stabilized, then you can consider of a surgical reconstruction, but not before. As long as you have an active disease activity, you have a great risk that you have scar, that you have an other inflammation, that you lose your reconstruction, and that you end in a disaster. So surgery in GPA seems to be possible, but only when the disease activity is very low under medical treatment.
What do you think about reconstruction, Martin?
Well,
consideration about it.
Well, I definitely agree that you should try to avoid operations as far as possible, as long as the patient have active disease. But I mean, most patients do respond to medical treatment in about half a year. They are in remission, and nowadays with rituximab, that is actually have shown better result for to keep people in remission. That you can be quite confident that that you can keep a remission for a few years. So it's good to wait, but when they are in remission, I think they usually or respond to surgery.
Okay, and we have a question here for you, Hans-Rudi. If operation on GPA patient either nasal or subglottic, do you use induction with steroids or perioperative systemic immunosuppression?
I didn't understand everything of the question. Which one is it?
CWV. It's quite in the middle. If you mean, do you use any induction steroids or perioperative systemic immunosuppression when you're operating a subglottic or something?
Well, you have seen the patient with the acute dacryocystitis in my presentation. He had GPA and he had an abscess of the tear sac, and so we had to go in. And there we tried to induce a immunosuppression. And by that time, we did not use cyclophosphamide or methotrexate. We used a systemic steroid treatment because we know that it works in these cases. So we tried that, and we had quite some stability under this treatment. So it is an idea, but again, probably you should discuss these cases with your team, with your internist or immunologists before you go in and perform surgery.
Okay, thank you very much. I think actually our time is out now because it's 9 o'clock. Is there something special that you two would like to send out to the participant on this webinar? Some take-home message?
Well, just one more remark to the questions here. Someone asked about elastase antibodies, and I think that is a very good remark, that it is common with drug-induced ANCA vasculitis to have multiple specificities, and especially elastase antibodies in the levomersol-induced cases. So it could be good to increase and to the testing and send it to a special laboratory if you have a patient where you find negative and you have a suspicion that they use cocaine.
Okay, then I think it's time for us to close this session. What do you say, Sean?
Yes, I'd just like to thank you, Cecilia. That's been a really stimulating webinar. It's been really good, and well done for putting it together, and huge thanks to Martin and Hans-Rudi for a really informative pair of talks. I learned a huge amount from that, and very grateful to you, gentlemen, so thank you very much. It just remains for me to thank the audience for taking part, for participating, and the ERS for setting this up. Our next webinar will be on the 2nd of December, and that's a hot controversies in rhinoplasty that Yanis Konstantinidis is going to chair. So we look forward to seeing you at that one. And once again, just thank you very much to our panel and to you too, Cecilia, and good evening to everybody else. Bye now.
Bye-bye.
Bye-bye.
Bye-bye.